وعلى آله وعلى آله وصحبه أجمعين. And of course, my first and foremost, good morning to my audience, ibu-ibu, bapak-bapak, professor-professor, and dosen-dosen of the University of Pajajaran Bandung, and to be more specific, students from Studi Anthropology, Fakultas Ilmu Sosial and Ilmu Politik, Universitas Pajajaran Bandung, Indonesia. And praise to Allah for the courage and barakah showered upon us on this special program. May Allah bless us all in the month of Ramadan. And I would like to also to take this great opportunity to congratulate Dr. Junaidi Harahap, Head of Department of Anthropology, and Dr. Ina Herawati and other members and organizing committee members for organizing this Dosen Tamu or invited lecture program. Shukran jazilan. So Alhamdulillah, for today's program, I'll be delivering a lecture entitled Medicine, Symbolic, Reality. And the content of my lecture will be, I need to share the screen, okay. The content of my presentation will be medicine, symbolic reality, medical system, healthcare system, biomedicine as a socio-cultural system, the new directions in the anthropology of biomedicine, and conclusion. I'm not sure whether I can do it in 60 minutes, but I'll try my very best. If I could not make it, we can stop somewhere to allow students for Q&A session. And before we go into the details of my lecture, so we need to see we need to have some kind of a conceptual understanding what medicine is all about. And we need to define in a losing manner so that we'll be able to understand the concept of medicines. Medicine deals with two different kinds of reality. So you have the so-called scientific reality, or you can put it differently as biophysical. And the second reality will be the ordinary reality, or to put it differently, you can say human science reality. And each of these reality has its own, governing principle to comply with. For scientific reality or biophysical reality, the governing principle is biological, physiological, and pathophysiological. And most of the modern medical theory, in the study of disease in particular, will be based on this principle. I mean, biological principle, physiological principle, and pathophysiological principle. Or in short, you can say scientific reasoning will be the source of reference. The keyword for this reality will be we are using scientific reasoning. But as for ordinary reality or human science reality, the governing principle involves socio-cultural premise. The deliberation of facts could be based on scientific reasoning, could be based on cultural reasoning, and also religious reasoning. So when we talk about scientific reasoning, we are looking at the empirical reality. We're talking about scientific tests and so on. But when we say cultural reasoning, the premise that we use could be cultural beliefs, and it is entirely relying very much on the tradition of the community or of the society itself. And when we talk about religious reasoning, we are talking about something to do with revealed knowledge, and the concept of halal and haram comes in, and the concept of Sharia compliance will be the key factor in understanding religious reasoning. The next issue here, the issue in question, what are the key points to ponder? So the key points in ponder means we could see biophysical reality, where the biophysical root of modern medicine has been used as the basis for a general critique of the whole of medicine, example, innocent health. So that means if the system is not relying on the scientific reasoning, so in other words, the system itself will receive the critics from the biophysical perspective. So, but the dilemma here is the dilemma lies on the issue of interpreting the abstraction of ill feeling, or as in the case of illness or health. So in the case of disease, and in the case of, to get the precise definition of illness and health. This, thus we wish to see medicine as a socio-cultural system, as practice and a human reality. This could bring us to appreciating and enormous contributions made by the existing medical system or healthcare system available in society. So in reality that we have, so far we have a kind of a structured medical system, not just in the modern medical system, but we also will be looking at the traditional medical system. It could be the Malay traditional medicine, it could be acupuncture, whatsoever. So that's what would be the challenge? What would be the challenge? Challenge in terms of to have medicine as a social cultural system. And again, we are not really appreciating other system, but our understanding of medical knowledge should not be confined, should not be limited to medicine's biophysical reality. That means our understanding of medical system should not just confined or limited to medicine's biophysical reality, which we say the scientific reality. So in other words, we need to have a socio-cultural approach to understand the whole medical system, not just when I say medical system, it covers the modern medical system as well as the traditional medical system, as we used to say. I mean, we used to have this kind of dichotomy, modern and traditional. But in actual fact, we should not have this kind of dichotomy. We can just have modern medicine as a medicine itself. It covers everything: the modern medical system, the Orang Asli medicine, the Chinese medicine, the traditional medicine. So in this case, when we employ the social cultural approach, it's a beginning to radically remake our understanding of medicine. So in other words, we should look at the medical system, regardless whether you are referring to modern or traditional. It has to be a holistic manner and employing the social cultural approach. So in this case, what will be the mediating factor here? So what kind of mediating factor? In other words, we need to form a bridging or unifying reality, combining the scientific reality and at the same time the social cultural reality, or which I mentioned just now, ordinary or human science reality. So the challenge now is how can we go about unify these two different realities and two different realities of having two different governing principles. One is scientific reality and the other one is on the non-scientific reality. So how we go about in this case. So it is important in this case for all of us to study, to have a comparative study of medical system. So we are not saying that this particular medicine is much better than the other. So we need to have a kind of comparative approach. And in other words, a comparative study of medical system where we get to appreciate the structure and the significance of medicine as a healthcare system. So, and again, when come to this particular point, we talk about studying medicine as a social and cultural enterprise, of which inviting broad philosophical inquiry into medicine. And again, we need to study medicine and with comparing with other medical systems available in the community. So what do you mean? What can we say about studying medicine as a social and cultural enterprise, of which inviting broad philosophical inquiry into medicine? So at this particular at this juncture, we need to understand. We need to understand that medical anthropologists seek to understand and to help others see that health is rooted in cultural conceptions, social connections, and human biology. So I repeat again, so at this particular point of view, we need to understand that medical anthropologists seek to understand and to help others see that health is rooted by these three important dimensions. One is cultural constructions. In this case, we talk about something to do with pain and culture, or something to do with cultural kind of experience, and then the second point will be the social connections. Here we are talking about the types of relation within the family, types of relation not just within the family, but within the society itself, within the organization itself. So, and in other words, in the case of social connection, we are talking about it could be doctor and patient relationship. It could be the indigenous healers and the patient. And again, we need to see health in the third dimension, the human biology, such as the threat of microscopic pathogens to bodily system, and to understand the concept of immunity, the concept of, and for example, let's say in the case of human biology, we talk about immunity, and this immunity, perhaps in the biophysical principle, we use the word immunity. And because of that, when we have COVID-19 vaccinations, it is meant to build one's immunity in the body. But as for sociocultural dimension, are we going to talk about immunity, or are we going to talk about invulnerability? So there are two different concepts here. So we talk about immunity, of which the term is very much reflect the biomedical framework, or we talk about invulnerability. So invulnerability could be not be this, is not similar to the concept of immunity. So you have two different concepts when we talk about human biology, from the scientific research, from scientific framework, or you can talk about invulnerability in terms of non-scientific framework, or perhaps we can even unify, you can even merge them together and come out with the new terms to explain about human biology from not just the scientific perspective, but at the same time from the social-cultural perspective. In other words, health is a bio. So by looking at this point, next slide. Okay, so by looking at these three dimensions here, cultural conceptions, social connections, and human biology, so our understanding of health covers biocultural and biosocial phenomena. So the concept of health is not just within the biophysical reality. It has to be, you need to redefine and to define or redefine that health is biocultural and it's a biosocial phenomena based on the understanding that both physical and social environments interaction determine the health of individuals and of whole populations. So now, in other words, we should see and we should define health in both perspectives, the biocultural perspective, at the same time using this biosocial perspective. In a way, what I'm trying to say here, we are not discussing having this kind of definition of health, which includes, which states that health is a biosocial phenomena. In a way, we are not discussing medicine as a biophysical reality, as far as health, disease, and illness are concerned. The reality of medicine is about bio. Okay, let me. It's not moving. Is okay. Right. Is so. The reality of medicine is actually about bioculturalism. Bioculturalism, which refers to the significant interactions that take place between biology and culture, and health and illness. And culture teaches us how to think about experience and respond to the sensation of pain. At the same time, in assessing a disease, it is important to consider how biology and culture interact. So cultural practices, on the other hand, may inhibit or promote disease spread, and conversely, disease can significantly mold culture. So in a way, what the reality of medicine now is not about biophysical, it's not about ordinary reality, it's about bioculturism, which I already defined here, and that it refers to a very important interaction that take place between biology and culture in health and illness. And the most difficult part, of course, when we try to define illness, when the patients go to see the doctor, and the patients will be talking about his or her ill feelings, I could say abstractions of ill feeling, and it is then we can see two different school of thoughts here. One, those who subscribe to scientific reasoning will try very much to reduce the abstractions of ill feeling into a definite protocol. So based on the ill feeling suffered by a patient, then the doctors or the medical doctors, the health practitioners in the biomedical framework will try very much to redefine it into a definite category, which they believe which they can prove scientifically about the symptoms that they are suffering. So in this case, it could be based on the ill feelings conveyed by the patients to the doctor, and doctors try to do all the tests, and then they come up with the idea of you might be suffering from hypertension, you might be suffering from diabetes, you might be suffering some kind of infections or stomach upset. All right. So that will be one kind of school of thoughts that will interpret the ill feelings of a patient. But the same patient, when he or she goes to see another healer, and of course it's not the doctors, it could be indigenous healer, the Pak Dukun or the Bomo or any traditional healers, they have their own protocol too. And of course the protocol would not be very much related to the biomedical framework. So they will have their own way to interpret it. And of course, at this particular point of view, the cultural reasoning will take place, or maybe could be religious reasoning will take place. So that means they will say, well, you have the ill feeling, and they are not going to narrow it down to a specific category like hypertension or diabetes, but they will try to understand the concept of illness rather than the concept of disease. So in this case, the framework that they will use will be the sociocultural framework, where they have the cultural beliefs and whatsoever. So culture teaches us how to think about, experience, and respond to the sensation of pain. So of course, there will be a kind of conflict of framework here. One is the scientific framework, the other one is a non-scientific framework. But the issue here is how, as a medical anthropologist, how are we going to negotiate these two frameworks into a unifying kind of reality? So this is something, is a great challenge to a medical anthropologist in understanding pain, not just from the biological principles, but at the same time to understand pain from the social-cultural framework point of view. Okay. And in other words, the biocultural model, okay, so biocultural model is a holistic model. It takes culture as a centering concept that must be reconciled with the realities of human biology and of ecosystem at all levels. So in other words, biocultural model appears to me, is from my point of view, is that it's a holistic model where where culture is the core concept in this particular model, and needs to be reconciled. We need to be, we need to harmonize it with the principle used in the biomedical framework and the rules that we use in the social cultural framework. So that will be a great challenge. And this biocultural model, in many ways, or inadvertently, implies that medical anthropology must be multidisciplinary, of which health and sickness to be the result of complex multi-factor interactions on biological, psychological, and social levels, not the results of simple determinants operating on only one level of analysis. The causal factors could be drawn from ethnographic, from clinical, from epidemiological, and socio-psychological sources. So that means what I'm trying to say here is, we as medical anthropologists, we are not going to work in silo. We are not going to work alone. We need to be multidisciplinary, or you can use the word interdisciplinary. So as to understand the whole issues of ill feelings, or I could say the word abstractions of ill feeling. It could be defined as a disease, or it could be defined as illness. So it depends on which context that we are talking about. So because why we had to be multidisciplinary, why we had to be interdisciplinary, because health and illness, or health and sickness is not involves the complex multi-factor interactions. So when you talk about ill feelings, we're not talking about just something wrong with the biological issues. There's something wrong with our physiological part of the body. That is not the issue here. The issue here is a multi-factor interactions on biological, on physiological, psychological, and social levels, and not the result of single determinants operating only on one level of analysis. So in other words, which I mentioned here, the causal factors can be drawn from ethnographic materials, or can be drawn from the clinical dimension, and it can also be drawn from epidemiological dimension, and it could be social psychological dimension. And this brings us to the next level of the second point that we could talk about, is about the medical system. So at the first part of my presentation, I was referring to how we go about interpreting or analyzing the concept of medicine. So which I already mentioned that medicine deals with two kinds of reality. So we have done that. So after we are able to grasp the concept well. So this brings us to the next level of understanding, the concept of medical system. So what do you mean by medical system? Medical system is an ordered, coherent body of ideas, values, and practices embedded in a given cultural context from which it derives its signification. What does it mean? Regardless whether which medical system we are talking about, either we are talking about the modern medicine, of course we do understand about this modern medical system is an ordered, coherent body of ideas, values, and practices. That is quite clear with us. But what about if you could allow me to use the word the traditional medical system that involves Chinese medicine, Iban medicine, Malay medicine, or the Orang Asli medicine, right? So regardless of whichever medical system that you are referring to, this medical system, either modern or traditional, we're still talking about an ordered, coherent body of ideas. They have their own ideas, they have their own values, they have own practices, and all these are well structured in the system, embedded in a given cultural context. So it depends on which culture you are referring to. So in other words, medical system employ different explanatory models to make sense of disease and give meaning to the individual and the social experience of illness. In other words, medical system, every medical system has its own models, and I use the word here, different explanatory models. You can have explanatory models for the modern medical system. You can also talk about explanatory models in the traditional medical system. So every medical system has its own structured system, and that includes a body of ideas, values, and practices, which I mentioned just now, embedded within the given medical system. And the jurisdiction of the medical system could be justified through scientific reasoning, could be justified through cultural reasoning, and could be justified through religious reasoning. In other words, it depends on which medical system that we are referring to. So maybe perhaps in the modern medical system, where we talk about the biophysical reality, the scientific reasoning takes the lead compared to cultural reasoning and religious reasoning. And we talk about medical system in the case of traditional medical system, Chinese, Malay, Orang Asli, Iban, or even the Baduy in Indonesia, perhaps, right? So in this case, maybe the cultural reasoning takes lead, or cultural reasoning supersede the scientific reasoning and religious reasoning. But if you talk about Islamic medicine, where the adoption of ru'yah approach, understanding ill feelings or health, then we could see the interpretation of ill feeling, which we can say illness or disease, can be done through religious reasoning. So in this case, in the case of Islamic medicine, I personally believe that religious reasoning will take lead in comparison with cultural reasoning and scientific reasoning. So in other words, we can see different medical systems will employ different explanatory models. So we can see, and these explanatory models are meant to make sense of disease. And this is a kind of how the issue of rationalization of disease, or rationalization of health, and rationalization of illness in this particular context. And every explanatory models that we talk about will take into account 5 important issues, right? Okay, we go here for a while. So explanatory models will take at least all these 5 features, important features. And the explanatory model will talk about, number 1, about etiology, the causal factor for the ill feelings suffered by the patient. So what will be the causal factor? So the explanatory model can be coming from the patient itself, or coming from the doctors itself. So maybe from the patients itself, they say maybe, well, my ill feeling is very much tied, is very much related to witchcraft or sorcery. But for the doctors' explanatory models, maybe the etiology has nothing to do with witchcraft or sorcery. So they have, maybe they talk about something to do with viral infection or whatsoever. So here, the etiology will be one of the features in the explanatory model that we observe. The second item under the explanatory model that we used to have for any explanatory model, we talk about onset of symptoms. What kind of symptoms that you are suffering? Okay, and the third point will be the pathophysiological or pathophysiology, means we are talking about physiological processes associated with disease or injury. For example, let's say we talk about diabetes. So when we talk about pathophysiology, maybe something wrong with the pancreas, right? That could be, when I say physiological processes associated with the disease. Okay, and then number 4 here, the item number 4, because of sickness, we talk about the severity or the type of syndrome adopted by the patient. The severity could be, I could say, could be what we call this chronic, or it could be short-term kind of sickness. It could be so-called acute. So in other words, the cause of sickness can be in 2 forms, the chronic type or the acute type. And if we are able to identify, we are able to diagnose the person is suffering from a kind of chronic disease, then we are talking about long life management. We are talking about long life health management. And then you can see when it involves a long life kind of management of disease, you can see when you look at the explanatory models of the patient, you can see there will be a kind of pluralism, medical pluralism, and the patients will adopt this kind of pluralistic attitude and combining all kinds of treatment or medication, not just in one medical system, but it could be more than one. So combination of one, or combination of 2, or can be more than that, because the issue here is about getting to search for a cure. That is more important for the patient, regardless whether you believe in that particular system or you disbelieve in the medical system. For a patient suffering from chronic disease, definitely they're going to talk about combining all kinds of medication in their in their treatment. Good example, we can talk about like cancer patient, patient suffering from stroke. All this requires more than one medical system as a source of reference. And of course, finally, when we talk about Azlan models, we talk about item number 5. Here we talk about treatment or healing acts. So that means healing acts closely linked with ideas about disease, closely linked with ideas about illness causation. So why I say so? Because in any medical system that we wish to adopt, our healing principles will be tied up with our ideas of causation. So if we believe that the ill feelings that we are suffering is very much to disease, then I think the healing acts will be more towards the biomedical framework, where the patients will decide to go to see the medical doctors or the biomedical practitioners. But if the ideas of ill feeling is very much to illness, which is more subjective and it's not really like disease, then the decision for treatment or the healing acts will be towards the non-biomedical framework. In other words, I could say we are going to employ the sociocultural framework as our source of reference in terms of treating our illness, right? So there are two different concepts here. We're talking about defining disease or defining ill feelings as an illness. So healing involves diagnosis as well as the way illness is perceived and experienced. So, but healing act, to say, and we talk about healing, it is not the outcome of, when we talk about healing, it is not the outcome of diagnostic acts, but the healing function is active from the outset in the way illness is perceived and experienced of illness organized. In other words, the medical systems function along the lines of the cultural dialectic, relating and treating both individual and social realities. And the social realities and cultural realities, or the social realities and cultural context, are well interwoven. So in this case, healing is not just about the outcome of diagnostic. For example, let's say it involves not just the cultural issues. It's not about the biophysical reality, but at the same time we talk about the cities and context. Good example, we can talk about in Malaysia. We have this one particular kind of seance that used to be a kind of ritual adopted by the Malays in treating any kind of illness related to spiritual illness. Malay seance involving a group of musicians and one Mindo, or the traditional healer, and talking to interaction between the group musician and the Pak Dukun, to identifying the source of illness. So you have a patient lying down, okay, is and surrounded by the group of musicians and the bomos and the Pak Dukuns, and of course surrounded by the committee members observing the event. And this ritual will be conducted as a part of treatment, a part of healing act, and the job of the Mindo, or the traditional healer, is to identify the source of illness for the patient. If the source of the illness is very much related to a kind of spirits, then they will deal the patient with the spirits and talking to the spirits, and at the same time the performance is meant to drive away all the evils within one's body. So it's a kind of healing rituals, and which is quite popular in the eastern countries, in Kelantan and Terengganu, and this is called mind putri. It's a kind of a traditional Malay seance. Okay, and it used to be a kind of healing rituals to treat a patient suffering from the spiritual kind of illness, not disease. So this is I could say the different concepts here. Either you're talking about disease, which has to conform with a certain kind of reality, or are you talking about illness, or which you need to comply with certain kind of reality? It could be in cultural context, it could be within the religious context. Okay, and then and this brings us to the next level of my lecture here. Point number 3 here is about healthcare system. So we need to see how the healthcare system works in reality. So this is a kind of healthcare system which I adopted and adapted from the work done by Arthur Kleinman in his article. So he mentioned about there are three social arenas, about the healthcare system. You can see here, number 1 here, you can see if down below here is about the popular sector. So the popular sector, it can be based and the jurisdiction could be individual based. Okay, or the jurisdiction can be family based, or the jurisdiction can be social nexus based, and finally it could be community based. When I talk about popular sector, individual based, when I say jurisdiction at the individual level, good example for this, that means we talk about self-medication. So sometimes you got stomach upset, we don't rush to the clinic to get the advice from the medical doctors. We do have our own perception, our belief. And this stomach upset is something that I'm used to be. For example, I got kind of flatulence, and then you thought that it will be moving in the body. So your understanding about your own physiology will be very much tied up to your cultural belief, and it is very much in cultural context. So in this case, you will decide not to go to see your medical or to see your physician to treat that kind of flatulence. So you believe that for this particular kind of ill health, I would rather just get the traditional ointment and rub over my stomach, and it heals perhaps. So they call it self-medication. There are many situations where all of us, we begin with this self-medication approach. In other words, we are in the popular sector. And from where we get all this kind of information of treating ourselves, we can get from the family itself. So the family keep on talking to us and telling us about how to go about treating that kind of ill symptoms that we are suffering in the case of flatulence or stomach upset. And the popular sector can also talk about family based. In other words, the jurisdiction here is more family based. When I talk about family based here, I'm talking about not so much about the treatment. It could be the family support in terms of a person when you are suffering from a kind of chronic disease, let's say cancer, stroke. I think for diabetes and hypertension, it's also considered as chronic, but not as chronic like cancer. What more if the doctors say a person is suffering from cancer stage 4 at the final stage, and you have 6 months to live. That kind of prognosis given by the doctor. So the doctor do some kind of diagnosis and saying that you're suffering from a kind of cancer symptoms, and the prognosis will be you can survive up to 6 months, maybe the most. So when come to this particular point of view, so you can see in the popular sector, the family support comes in. Family support comes in not just in terms of physical support, it can be the moral support, social support, and even financial support, and even telling you about the next context in terms of healers. So all the family members start searching what would be the best treatment for the cancer patient. Okay, and the social nexus here, we talk about social network. Okay, social network within the community, and I think it's well understood here. And finally, we had a community base. So all this individual-based, family-based, social nexus-based, and community-based, all this comes under popular sector. Right? Okay, you can see there's an arrow here, arrow going into the big circle here. So you talk about beliefs, you talk about choices, you talk about decisions, roles, relationship, interaction, setting, you talk about institutions, and many more. And the second sector which I want to talk about will be a folk sector. So the folk sector means you're talking about the non-professional healing specialists. And this comes in the Pak Dukun and Bomo and other indigenous healers, or among the Malaysian Aborigines, they're called Halak. I mean, the kind of Bomo too, but they have a different term. So this folk sector, the popular sector is more you and family and networks and community. But we can't talk about folk sector. We are talking about the so-called non-professional healing specialists. And you can see they have their own methods, they have their own mechanisms to treat the patient. And it can be, the traditional can be in trance state, all right? It can be in another world. Just the one that I mentioned just now, the mindful tree, where the Bomo is will start the conversation between the Bomo in this world and the other person in another world. So they're talking to the spirits. In the Malay traditional sounds known as Main Putri. This is a kind of folk sector. Or you can also talk about a traditional gynecologist known as traditional midwife. Of course, we don't call it gynecologist, but I use the word here, traditional gynecologist. In other words, we will employ the traditional midwives to come over and to give some advice how to go about, how to treat the newly mothers to be in for the mothers during their postpartum period. So they have all kinds of items. They have all kinds of advisors where not see the patient, the mother during the postpartum period, they need to comply with the suggestion advice given by the traditional gynecologist. But still, you talk about the when you talk about the midwives, even though it's traditional, but still they are considered as non-professional healing specialists. So you can name it. Another common, which is no longer in practice in Malaysia, maybe is the Tok Mudim, the traditional circumciser. Okay, where this is a specialist. Okay, traditional Malay circumciser, or in Malay called Tok Mudim. Where you go for this called circumcision. So this also specialists, but in their own terms, okay, but not in the professional term that we used to have in a professional sector. And then you have the third arenas. You're talking about professional sector, consists of professional scientific Western medicine, or you can say modern medical specialists. And at the same time, we all need to also clear our doubts. We are not talking just about professional scientific specialists. We're also talking about professionalized indigenous healing traditions. For example, like chiropractor, and then we have acupuncture, moxibustion, Ayurvedic, or Chinese medicine. This also comes under professional sector because they have a proper training to become this professionalized indigenous healing tradition. To be a chiropractor, they need to undergo certain programs. They need to take certain courses to be a specialist. Okay, as a chiropractor, or you need to be specialist in Ayurveda. So it's quite common in India, and there are many schools teaching us how to be and how to practice Ayurveda. So they have certain courses, certain syllabus where a person needs to complete. Okay, once you satisfy the requirements, then only you can become a specialist in Ayurveda. Similarly, in the case of Chinese medicine, they have their own course too. They have to learn a different kind of anatomy. Or in a modern medical system, they have the subject called anatomy. But and it is so in the case of Chinese medicine, they do have also their own understanding of their own anatomy to understand our own body, and they go for the concept of meridian line. So for Chinese medicine, you can see they talk about more on meridians. You have the stomach meridian, the lung meridian, and the ear meridian. Okay, all these meridians is a kind of will be one of the important syllabus in the Chinese medicine. So as you can see, when they employ acupuncture as a treating mechanism to the patient, they're not just using any needles and poke any parts of the body. That is not it's not acupuncture, right? So what they are doing, they are going to have the needles, the small needle, and start to poke all these needles. I could say the word there, and along the line of meridians. It's not just simply use the needles and you can poke any parts of the body. That is not acupuncture anyway. So in other words, what I'm trying to say here, when you talk about healthcare system, we will encounter these three different social arenas, and those arenas contain and help construct distinct forms of social reality. This is the reality that we have as far as the healthcare systems is concerned. So we talk about this arena represents socially legitimated context of sickness and care. So, and if you look at if you read this Arthur Kramer's work, he says that he classified this the three sector as a separate clinical realities. So you have the popular sector, and they have their own clinical realities. We have the folk sector, they have their own methods as far as clinical realities are concerned. And of course, for professional sector, it's quite clear that we do understand about the clinical realities. Okay, and then and this brings us to the next level of the important topic. Point number 4 here, biomedicine as a sociocultural system, meaning that how can we go about understanding this biomedical or biomedicine as a sociocultural system? So in this particular topic, there are two main issues involved. One is anthropological studies of biomedical practice. So how we anthropologists and how we medical anthropologists in particular, okay, study biomedical practice using our own method and of course with our own flavor. So of course when we talk about anthropological studies of biomedical practice, how can we go about understanding these biomedical practice or biomedical circles under anthropological framework? In other words, we begin to employ anthropological flavor in understanding the biomedical practice, because it's a great challenge for us as anthropologists and medical anthropology. And then the second issue that we talk about in the biomedicine and social cultural system will be new directions in the anthropology of medicine. So what are the issues that can be highlighted, that can be classified or can be categorized as a new directions in the anthropology of medicine? So let's look at point number 1, anthropological studies of biomedical practice. So under these anthropological studies of biomedical practice, I'm going to talk about 5 important features. I could say 5 important areas that are of our concern. Number 1, we need to understand the domain of medicine here. The domain of medicine. So if we are anthropologists, if we wanted to study the biomedical practice, we need to understand the domain of medicine. Which medicine? The domain of biomedical practice. Okay, and point number 2, we need to understand also the biomedical division of labor. And the third point, we need to understand the social relations of biomedicine. And the 4th, we talk about socialization, the reproduction of biomedicine, and finally, number 5, we talk about the production of biomedical knowledge. And it is very much related to a kind of research to be carried out in the biomedical setting using anthropological method. Okay. So under the domain of medicine, these are some of the issues we can talk about under the domain of medicine. We can talk about human physiology. So human physiology, of course, in a biomedical framework, they have their own syllabus, they have their own understanding, they have their own knowledge in relation to human physiology, which is entirely different from the community itself, from the layman perception. So being anthropology, we need to see the human physiological understanding from the, I would say, from the scientific point of view, and we can also understand human physiology from the cultural point of view. So, of course, as I mentioned to you just now, let's say one term we talk about immunity. So it's quite common, the words immunity being used in a modern medical system. But how do you explain immunity in the context of culture? And in the context of cultural beliefs, we don't talk about immunity. We talk about invulnerability. So you may talk about invulnerability. So when you talk about ill feelings, you are talking about, the body is invulnerable, is in a vulnerable state. We don't say the body but of course in the modern medicine they talk about immunity, but we talk about, let's say, in the case of mothers during the postpartum period. So mothers during the postpartum period, they will be classified as they are in a invulnerable state. They will be in a vulnerable state. Invulnerable. So because they're losing blood after giving birth and so on. So so that means the body now becomes in a cold state. And that would be the understanding about human physiology in the case of traditional medicine. And then because of more blood, they're losing more blood, so now they are in a cold state. So the rationale for the treatment will be, you begin to apply the hot kind of treatment, hot medicines. That's why you can see mothers during the postpartum period, they employ everything hot. They drink coffee and crackers, and they have the seated iron bar to heat the abdomen, wearing shirts with all the help with the hot medicines in it. So everything hot, right? And even massage, they use the traditional ointment, but still in a hot kind of treatment, okay, to remove the winds found in the body. So when most of us among the Malays, they believe that when a person is under postpartum period, they said your body now in a cold state, not just a cold state, but you have more wind in the body. So this kind of understanding of physiological issues when you compare between the scientific reasoning and the cultural reasoning, and what more you talk about religious reasoning. And of course, under the domain of medicine again, one number 2 here is separated from religion and politics and economics and arts. And of course, the definition of medicine related to drug. And of course, in the biomedicine, the central concern to biomedicine is their body is in disease. Okay, and number 5, in the domain of medicine, treating disease instead of illness. So you can come in, being anthropologists, you can study this domain of medicine. You can compare about the concept of disease and the concept of illness. The concept of disease is a natural process, but concept of illness is very subjective. Okay, so the main point under illness is the concept of subjectivity. And of course, in the modern medicine and in the scientific arguments, they talk about physical reductionism and physiological integrity. So this is all I could say, I have listed down 6 main-ish points under the domain of medicine. Okay, all right. So I think how many minutes more that I have, Dr. Irna Herawati?
We still have 30 minutes left, but maybe we can just have a short break so students can raise questions. Do you mind?
All right, yeah, I don't mind. Yeah, please.
Okay.
Any
questions?
I need to take a break.
Dari mahasiswa, silahkan. Bila ada pertanyaan. Halo? Ada pertanyaan belum? Tolong dijawab ya. Boleh dalam bahasa Indonesia, tidak apa-apa.
Ya, boleh. Ya, boleh.
Ya, boleh.
Boleh.
Pak Azlan juga paham bahasa Indonesia.
I can speak Malay, don't worry.
Ya, okay. We have one student raise his hand. Fala,
Okay.
silakan Fala.
in Indonesia atau in English, Bu?
Ya,
Bebas, silakan Hala.
bahasa Indonesia pun boleh. Tak apa.
Okay, I'll try in English first. Thank you for Dr. Noor for the presentation. There are certain things that I want to ask is about that. This is a question that as a student of anthropology that we will always thinking about in the future, that what we can be to as a anthropologist to participate or to contribute for our country. And my question is the same thing for the anthropology and medicine. Is there any certain profession that we can apply for when we graduate from our studies, that for students that who want to apply his knowledge in anthropology medicine, but sometimes that we don't know that what kind of profession that we can apply. So is there a certain profession that we can use, we can apply or to aim in the future that when we graduate from our studies? Thank you, sir.
Thank you. Okay, a good question from Brother Falas Fajari. Okay, let me respond in this way. When you study human sciences, subject like anthropology, sociology, and communication, whatever. So we are producing, I could say the word that we used to say, generalists. Generalists. Okay, generalist means that we are not professional. We are not doing a program that like law, medicine, pharmacy. So when you do pharmacy, you become pharmacist. When you do law, you become lawyer. When you do medicine, you become medical doctor. But when you do anthropology, of course, you become anthropologist. But then we don't have a special career talking about being anthropologist, or a career talking about being sociologist. So the question now here is, how can we apply? So how can we work? How can we apply anthropology in our career? So it depends. So if in the case of medical anthropology, you can work, you can be part. Just now I mentioned in my talk, I did mention medical anthropologists can never work alone. We have to be multidisciplinary. So multidisciplinary means being a medical anthropologist, you can work in a hospital too, right? You can work in a hospital, and you can work together with the medical biomedical practitioners, and you are conveying the ideas from your own from using anthropological flavor in understanding issues related to hospital environment. So it depends. You can talk about, let's say you want to study about, let's say the doctors talk about diabetes, for example. Of course, the medical doctor will explain everything through his own protocol, being a medical doctor. But you can jump in as a medical anthropologist and to tell the doctor that there's a certain part of which the doctor will not cover in terms, let's say, when it comes to follow-up treatment. Okay, I want to give a kind of medical education campaign, health education campaign. You can work on that. Okay, so you can use your knowledge on health and on health issues and to work together with the medical team. And in office, so anthropologists, as mentioned to you, we need to be working together with other groups, even with the professional. Similarly, we talk about you want to study about poverty, right? You can work together with other disciplines and use your anthropological principles. You can use your anthropological methods. You can use anthropological theoretical knowledge to understand the issues faced by the community. There are many issues in the community that you can figure out, and we can use whatever our professional skills. I could say, even though we do anthropology, we have our professional skill. Particularly, one of the professional methods that we used to have, the concept of ethnography. This is something is our strength when we use ethnographic. We can have clinical ethnography kind of work to talk about health issues, or critical ethnography. We can talk about social issues in the community like poverty and what more. And this is my general kind of observation for this discipline. But you don't expect this a professional career like law and medicine, pharmacy, or allied health and so on. So they have their own career, which is can tie up immediately to the subject they learn in the university. Okay, brother? Sure. Thank you.
Thank you very much, sir.
Dr. Azlan. There is one more question in the chat. I think it's from Malaysia, from Noor Effendi. Is there a medical anthropology major and scholarships for doctoral programs in Indonesia or Malaysia? Maybe you can answer about this question. Any information?
In Malaysia, is there a medical anthropology major? Yeah, I mean, if you do master's program, you can join our program in our department in IUM, and you can have supervisors can guide you through to do this subject matter using medical anthropological kind of methods. I'm not sure about in Indonesia. Is there anything in Pajajaran?
We don't have yet, but maybe there is no specific scholarship for medical anthropology, but there are plenty scholarship for studying anthropology. But when the student wants to do a topic in medical anthropology, of course, it is allowed. So there are plenty of opportunities for the scholarship in anthropology, and I think one of the topic can be in medical anthropology. That's what I can inform.
I think I do agree with Dr. Nairawati. We don't have a kind of a specific program purely medical anthropology so far. We don't have it. But we can supervise PhD or masters doing a topic in medical anthropology. But to have a program established by itself as a medical anthropology, we don't have it so far for the time being. But maybe in the future, we do not know. Sure. Thank you for the question.
Yeah, probably. Thank you, Dr. Azlan. Now you can continue with your presentation. Still
okay. So, inshallah, thank you. Allow me to go through. So we have the second features of anthropological studies in biomedicine will be what is so-called biomedical division of labor. So biomedical division of labor, here we talk about division of labor within biomedicine institutions. Of course, when I say anthropological study, we can study the division of labor within the biomedicine institution. We can talk about physicians, medical doctors, nurses, pharmacists, technicians, public health officers, and administrators. So we can make a study, anthropological study, to understand these DOL issues in biomedicine. Okay, maybe the lifestyles, maybe some administrative procedures involved with the hospital. We can study about hospital environment and so on. So biomedicine established its legal status as a virtual medical monopoly. This is, we don't understand about this. And I mean, when we study about division of labor, I mean, we are talking about, we study about the ideology, the practice, to understand the behavior of the medical specialists in the hospital, the workload, everything using anthropological approach, and the product of ongoing politics of legitimization. And this is more about something to talking about endorsing the biomedical division of labor in that context. And the third, I could say, another important areas of where anthropological studies can be done in the, what do you call this, in the biomedicine. You can talk about, you can even study the social relations of biomedicine. So what are the things that we can talk about under social relations of biomedicine here? We can talk about the healing relationships. I mean, we can talk about, we can make a study, a doctor and patient relationship in the hospital context. So what are the areas, what are the main concern between patients and doctors here, as far as healing relationships are concerned? Of course, the doctors really have their own protocol, they have their own explanatory model about healing matters when they deal with the patient, and the patients do also have their own explanatory models. They have their own kind of worldview about their own sickness or their own illness or disease. So we can study how we can go about unifying these two different realities or two different explanatory models. One explanatory model seems to tie up very much to the biomedical or biophysical reality, and the other side we have patients where they have this cultural reasoning and religious reasoning play important role in comparison with the scientific reasoning. So you can see that we are kind of not say a conflict. Our job here, how we can unify these two different realities, or two different separate realities. The other things we can talk about under sociology of biomedicine, there's a term called detached concern. Detached concern means you're talking about the when you see the doctors, they are very concerned about your sickness. They're very concerned about your symptoms that you are suffering. So they look at your medical history, look at your background, everything. It seems that the doctors are very much into it, and they're very much concerned of your sickness or your symptom. That is from our observation. But the term that we use in reality in the biomedical setting will be the detached concern. I'm very concerned about you, but at the same time, I'm going to retain my professionalism. So that means you will like to investigate further about the symptom he or she is suffering by looking at the medical history or based on the historical evidence that you can get, that you can secure. But at the same time, the doctors will look you as a patient, and that means the medical doctors or the specialists will try very much to retain his or her professionalism in dealing with your case. So this is called detached concern. I'm not really going into something more emotional here. So they can see the doctors, they have to protect, they have to stay a little bit away from these emotional ties between the doctors and the patient, because to stick to what I call this professionalism, and of course something to do with integrity. Biomedicine as a social system involving an exchange of value that is thing and intangible. Of course, here you talk about services. You're talking about providing services. I can see exchange of value and disvalue thing. Let's say we can talk about you go to the government hospital. You can see you have to join the queue. It could be the services can be given to you another 6 months or another 3 months because you have a long queue. When you talk about hospital treatment and so on. But if you go to private hospital, the same sickness that you are suffering, you might be entertained just within hours, or maybe you just take a few days, and the doctors, the specialists will treat you within days, not within months. You are not going to join the queue, and the doctors in the private sector they are more willing to provide the service and in due course. So that means in this case, the only thing that you have to do in the private sector it has to be something to do with your money. So if you have more money, okay, if you are able to spend for it, so by all means. So that means so you can see this called exchange of value and disvalue. They are talking about services. There are different services offered by the government hospital. You can see a clear disparity between services provided by the government hospital and services provided by the private hospitals. And then, of course, biomedical context and rituals. In this case, we need to understand anthropological study will be looking at the biomedical context and ritual. Here, a good example I could say, maybe you talk about OT, operation theater. So you talk about, they have their own procedures, they have their own protocols when they wish to do an operation, okay? And theoretical positions and social relations observed in the biomedical setting or other. Of course, in the biomedical setting and the medical setting, we have a different kind of theoretical positions to understand the social relations within that particular context. Okay, and number 4, let me move. Okay, it's not moving. Okay, so socialization. Socialization means you talk about the reproduction of biomedicine. So in this case, I think it's more about learning process and how they become doctors and how they become specialists. So you have this medical education, and social life, being a specialist, is a perpetual socialization, a training for uncertainty and detest. I think these are morely about training to be a medical doctor. Okay, you can see the given here, Dr. X, Dr. Y, Dr. Z. So these are all just what I call this a simplified version, I could say, under this particular topic. Okay, we have a few more minutes. I think we have only 50 minutes left, I think. So the production of biomedical knowledge. In this case, that we talk about what kind of research that we can go in. So how medical anthropologists can go in and to do research together with the biomedical team, biomedical practitioners. So we can do biomedical research in terms of we can have video ethnography, we can have this video, we can have this ethnographic, we can have clinical ethnography research. So we can do ethnography experiments we can talk about mental health issues, we can talk about cultural beliefs in relation to psychiatric issues, we can talk about cultural beliefs in terms of not only psychiatric issues, we can talk about the culture-bound syndrome, right? And because culture-bound syndrome means there are certain psychiatric issues which can never meet or satisfy the ingredients of the psychiatric terminology. For example, in psychiatric terminology, they have many terms when you talk about mental health. You can talk about the schizophrenia. You can talk about Alzheimer's disease. You can talk about not just about dementia. You can talk about the bipolar disorder. So all these are terms which is commonly or frequently used by the specialists, by the psychiatrists, or it may be something to do with neurologists. Can use the Parkinson disease and so on. So, and anthropologists there are certain in the community where you have this culture-bound syndrome, which doesn't fit to any of the characteristics of the one which I mentioned to you. So where they don't have any clear characteristics of the disease suffered by the patient, they will lump them together into one term called culture-bound syndrome. I think being medical anthropology student, we know about this, the choral kind of symptom, choral, which is to be is quite common among Indians in West Bengal. You can have the susto. Okay, you have a kind of psychiatric illness like amo, right? Amo is another Malay term, and this amo is a common psychiatric problems that used to be in the Malay community. So and amo, lata, koro, sasto, all these all terms considered as the psychiatrists will not be able to reclassify them within their own psychiatric dichotomy. So in this case, since they don't have the terms to classify them, so automatically koro, lata, amo, and what this other mental problem will be lumped into one category called culture-bound syndrome. Okay, where the principle to explain will be more on culture rather than the non-cultural issues. Okay, and then what will be the new direction? I think I have 2 more slides to go, inshallah. I think I have to be very quick. So under new directions here, we can talk about we can have integrated methodology, and of course, I think being an anthropologist, we have a strength. We are good. We are strong in ethnography. So I think that will be another examples we can talk about. We can use ethnography in a biomedical setting, and how these ethnographic materials can really facilitate or assist the biomedical practitioners within their own environment. So we can have doctor-patient relationship. We can study about that. We can have comparative study of medical system, which I used to say in the earlier discussion. And then if I could go straight the last point here. So as far as new areas of biomedicine studies, we can talk about gender studies, pharmaceutical studies, biopower, bioethics, biocitizenship, biosociality, and many more. So I think biomedicine and human rights and so on. I think that's about it for my presentation. And of course, these are the references that I used to refer for my presentation today. So that's it. I think, thank you. Back to Dr. Ina Herawati. I think that's about it for my presentation this morning. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Azlan, for very deep information about mapping out the medical anthropology topics, and this is very useful for us. But we still have 2 questions. Do you mind to answer them?
Oh yeah, okay, yeah, please. Yeah, inshallah.
Yeah, we have 2 of them in the chat. First, questions from Mila. She would like to ask how a biomedicine system can covering a preventive and promotive of health. And the second question, we have traditional knowledge of medicine, how to implementing the traditional knowledge to biomedicine.
Okay.
That's 2 questions from Mila in the chat.
Right. Yeah. How a biomedicine system can covering a preventive and promotive of health. We have traditional knowledge of medicine. How? Okay, I think I can just lump these 2 questions in my answer. I think we have to understand reality that in reality that we are dealing with, which I mentioned in my first part of my lecture, that we have 2 kinds of reality. So whether we like it or not, we have this the so-called biomedical kind of reality, which is a biophysical kind of reality, which is more to the biomedical framework. At the same time, we also have the sociocultural framework where all these traditional issues, traditional knowledge of medicine comes in and so on. So the issue here is how, that means, of course, how a biomedicine system can covering preventive. Yeah, I think as far as biomedical framework is concerned, they have done, as far as health is concerned, they have done a lot. So, and there's no doubt, they have many programs. I can see the contribution is enormous. You just name it, whatever areas we talk about public health, and this biomedical framework will come in. Okay, of course, the issues discussed by the biomedical practitioners will be about topic scientific. I think just for example, like COVID-19, a good example of COVID-19. So so far we have to say that we subscribe more to the biomedical kind of approach. We have the vaccination, we have the booster, but at the same time we do have we do have people who is really don't believe with this kind of vaccination, so they had to go for another kind of treatment. But I think that the bottom line, whether you go to the biomedical or traditional, within themselves, they need a cure, or they need something called preventive measure. The only thing that which one is more convincing? Okay, so some people believe the scientific reasoning would be the best option. So then, if your scientific reasoning comes in, so you go for vaccination. But if you adopt the cultural reasoning, religious reasoning more than the scientific reasoning, then the person would not go to the scientific, they go to the traditional kind of knowledge. But it doesn't matter whichever side they still want to be cured, or they want to be they adopt this some kind of preventive measures to deal with the matter as far as COVID-19 pandemic is concerned. Okay, and of course the question how to implementing the traditional knowledge to biomedicine. We are not in this case. We are not saying that traditional knowledge can supersede the biomedical knowledge. What we want to do is we want to work together, kind of like complementary medicine, right? So we have, let's say, for the doctors, once the mother delivers the baby, okay, fine. You are given 40 days or 60 days for your postpartum period. So maybe the massage can come in. Okay, massage is nothing wrong with the. It's not in conflict with biomedicine. So you can go for massage, no problem. So we want to have a kind of indigenous knowledge and the biomedical knowledge work side by side. Okay, we're not saying that we want to implement our indigenous knowledge more than the biomedical. No, we have to work side. Which area that we can come in to help to ease or to facilitate the biomedical kind of situation. Okay, that would be. I think that will be. I hope I answered the question anyway. All right. Okay.
Okay. Danny, do you think your question has been answered as well? Hello, Danny.
Yeah, I think my question has been answered. So thank you,
Okay,
Mr.
thank you very much. Time is running out, Dr. Azlan, but we would like to welcome you again on the 13th of May, because next week we will start our Idul Fitri holiday, starting from the 29th until the 6th of May. Okay. So we'll see you again on the 13th of May with the topic on medicine as a cultural system. So we will see you again next month. Have a long holiday and a happy one. And
thank you.
Healthy always. See you.
Thank you again.
Warahmatullahi wabarakatuh.
Thank you to Katarina, and thank you to all. Thank you very much for giving us. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you. Selamat berpuasa.
Waalaikumsalam warahmatullahi wabarakatuh.
All right. Yeah, I can leave now, inshallah.
Yes, please. Thank you very much. I have to record.
How to, let me see.